Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. We're going to continue on with the top 200 drugs. We are winding down. We are at 176 through 180 today. And as a reminder, go check out reallifepharmacology.com. We've got that free 31-page PDF. Simply an email will get you access to that. Some of my most important clinical practice pearls, as well as things that show up on board exams and pharmacology exams throughout your career. So again, simply an email will get you access to that. We also get you updates when we've got new content, new podcasts, and other things available as well. All right, let's get into 176. That is Prednisolone. Brand name of this is Pediapred or Orapred. This is a corticosteroid, so similar, as you could expect with the name, to medication like prednisone. Indications, any type of situation where you've got some inflammatory issues going on. So asthma, COPD, severe allergic like skin reactions, that type of thing. Autoimmune diseases like rheumatoid arthritis also can be used for transplant patients as well to try to prevent rejection. So those are some of the major indications. Prednisolone specifically in practice, I probably see utilized for an asthma exacerbation if I had to pick one that I see probably most commonly. So ultimately this drug reduces inflammation by suppressing those inflammatory immune responses. So reducing pro-inflammatory cytokines and prostaglandins, and also the migration of leukocytes around the body. So that's the mechanism of action, how the medication works. A couple things I wanted to mention. There are some different dosage forms. I'm obviously probably talking about systemic prednisolone use here mostly. There is an ophthalmic formulation. And then in pediatrics, we see the oral solution used a fair amount there. A couple things about administration. Earlier in the day, take with food. And that ties into some of the adverse effects. So GI upset, that's why we try to give it with food if possible. And then insomnia. So those are really the short-term effects. So for giving a prednisolone burst, those are probably the most common reports of issues that you're going to hear patients report. A few other things, if patients have other conditions such as diabetes, hypertension, CHF, and fluid retention, this can all worsen those. So it can cause higher blood sugars, it can raise blood pressure, it can cause fluid retention. It can worsen acne as well if we're giving this in younger patients. That may be an issue. Also can have some mood changes as well. Rare, more likely with long-term use, you've got HPA suppression. In pediatric patients, again, longer-term use, it can potentially suppress growth if we're using it too much, too long, too often. And then, of course, the development of diabetes as well as osteoporosis risk in longer-term use. It can suppress the immune system, so naturally we may be at a little bit more risk for infection. Again, higher dose, longer-term use, that's more and more likely. And then glaucoma is also another potential complication that may occur if we have longer-term use. All right, let's get into drug-drug interactions. CYP3A4 does have a role here. CYP3A4 inhibitors can raise concentrations. CYP3A4 inducers can lower concentrations. So something to pay attention to there. One big one I see a lot in geriatrics, particularly with corticosteroids in general, like prednisolone, NSAIDs, anticoagulants, these can increase the risk for GI bleed. Okay, so that's something important to remember. Again, if we're only using this short term, hopefully it's not too big of an issue. But I have seen situations where patients are at higher risk for, let's say, GI bleed, and we give them, a 2-week PPI, or a 1 week, or however long that prednisolone lasts. We give that with that prednisolone. Now, important that you tackle polypharmacy and make sure that PPI goes away after the steroid goes away, because I've seen that plenty of times too, where we start a corticosteroid and then, 2, 3, 4 days later, they're reporting like some GI upset, some stomach pain, maybe some, GERD related type symptoms. And we start a PPI, and then those symptoms resolve, and the corticosteroid like prednisolone gets done, and then the PPI just kind of hangs on board. Okay, so important drug interaction to recognize there. I do think about the hyperglycemia risk, so it may kind of counteract what we're trying to do with, insulins or GLP-1s, or you name your diabetes medication, so pay attention to that. Fluoroquinolones actually can have an increased risk of tendon rupture. It's a warning, a precaution with fluoroquinolones. Well, corticosteroids like prednisolone can actually increase that risk. All right, moving on, we've got 177. This is Advil. The generic name is Ibuprofen. This is an NSAID. Okay, so it's an analgesic medication. It's a non-selective inhibitor of both COX-1 and COX-2, and ultimately this reduces inflammatory prostaglandins and pain-related prostaglandins is how that's primarily going to work. Indications, obviously any type of inflammatory pain, probably the sprained ankles, you're even associated with disease states like rheumatoid arthritis, osteoarthritis, not so much as inflammatory as rheumatoid arthritis, but ibuprofen and NSAIDs have a role in managing that as well. We've got headaches, migraines specifically, as well as tension headaches and other types of headaches. Dysmenorrhea is another example of something that we may use this medication to treat. Fever, very, very common in pediatric patients especially, and the use of ibuprofen definitely happens in that patient population as well. So again, kind of going a little deeper into that mechanism of action, again, we're reducing those pro-inflammatory prostaglandins by inhibiting, more specifically, COX-2 enzymes from producing them. Remember, ibuprofen's non-selective. It hits COX-1 as well, which that can release, that can increase the risk for bleeding and kind of affect those platelets a little bit. Many different dosage forms of ibuprofen available. Make sure that you've got dosing down if you're using this medication for pediatric patients and their parents or caregivers. Make sure that they understand how to dose it. Okay, there's always numerous overdose cases, errors reported in dosing where too much is given. Okay, so we really, really got to make sure that our patients are educated when we're using liquid formulations like that they're getting the appropriate amount. I've seen a lot of mistakes in practice with that for sure. Take with food to avoid GI upset. So again, that's one of the kind of common adverse effects with this. So give it with food in general. Rare adverse effects, GI bleed, of course, nephrotoxicity. So that's maybe more so particular in combination with other medications that cause nephrotoxicity, and I'll talk about that a little bit in drug interactions. And then there is a boxed warning for increased risk of cardiovascular events, as well as the GI bleed or ulceration risk there as well. Less common, they can raise hypertension and potentially cause some fluid retention. So, these aren't the greatest drugs as patients get older generally, because they often have cardiovascular concerns in addition to the GI bleed risk concern as well. So let's dig into those drug interactions a little bit more. So first and foremost, I look for antiplatelet and anticoagulant medications. So adding a medication like ibuprofen on top of apixaban, warfarin, heparin, whatever anticoagulant, antiplatelet medication you want to think of, that's going to increase the risk for GI bleed. So you really, really got to pay attention to that for sure. The other thing I really wanted to mention was nephrotoxicity risk. So patients on diuretics, on ACE inhibitors, on some of the immunosuppressives like cyclosporin, tacrolimus, aminoglycosides like gentamicin. These can all have that combination of increasing the risk of renal toxicity. So something we really, really got to pay attention to there for sure. All right, moving on, we got 178. Brand name is Aceon. Generic name is perindopril. This is an ACE inhibitor, as you could imagine by that ending, PRIL. That's always kind of a dead giveaway for a medication that's likely an ACE inhibitor. So what do ACE inhibitors do? They inhibit the ACE enzyme. So what does the ACE enzyme do? It converts angiotensin 1 to angiotensin 2. So by blocking that formation of angiotensin 2, we're going to cause vasodilation. Angiotensin 2 itself causes vasoconstriction. So by blocking the production of angiotensin 2, we're going to cause the opposite to happen. Administration, dosing, ideal to take on an empty stomach 1 to 2 hours before a meal. It's typically once daily dosing. I haven't seen this medication used much anymore. You see, lisinopril, maybe a ramipril, many other ACE inhibitors ahead of this medication. From an adverse drug reaction standpoint, elevations in potassium, that's number one. You're going to be tested on that on board exam, pharmacology exam. ACE inhibitors cause a rise in potassium, and we need to monitor for that. The other thing that always gets asked is cough. ACE inhibitors are notorious for a dry, kind of a hacking type cough. So if you have a patient that has a cough for a week, 2 weeks, 3 weeks, and beyond, you better double check the medication list and make sure they're not on a medication like Aceon here. Some rare adverse effects, angioedema. Obviously, it can drop blood pressure, so it can drop it too far. We can get some orthostatic hypotension there as well. And then in pregnancy, this class of medication, in general, the ACE inhibitors are recommended to be avoided. They are contraindicated in pregnancy and can cause some risks to the fetus. So definitely a no-no in pregnancy. All right, drug interactions. So I alluded to NSAIDs before. They can increase that risk for renal damage, so that's definitely important to remember. And then I think of other medications that can raise potassium levels. So potassium-sparing diuretics like spironolactone. ARBs, we shouldn't use ARBs. So that's like losartan. We shouldn't use it in combination with a medication like Aceon here. Obviously, potassium supplements, and one that kind of slides under the radar is an antibiotic for infection, trimethoprim. That actually can raise potassium there as well. Other interactions to think about, anytime we add another blood pressure lowering medication, obviously that can increase the risk for hypotension. And then other medications that can cause renal impairment may increase the risk for nephrotoxicity. So I alluded to NSAIDs already before, but we've also got medications like loop diuretics that may increase the risk for dehydration and kind of have that additive effect on the nephrotoxicity risk with Aceon. If you guys are looking for more resources, go to meded101.com/store. We've got pharmacist board certification study materials like BCPS, NAPLEX, ambulatory care, geriatrics, BCM-TMS. We've also got books for nurses. We've got books for med students. We've got lots of different content available. I'm coming out with a newer book, a nursing crossword puzzle book that's basically geared towards pharmacology, so I think you're going to find that useful. So definitely go check that out, or I will have that available at the website meded101.com/store when that becomes available as well. So again, all your support, any books, anything purchased at meded101.com/store goes directly to help this podcast, helps me keep it free and available for all to benefit from. So greatly appreciate your support there. Again, go check out all the resources, links, meded101.com/store if you want to support this podcast. All right, we've got 179. This is Deseril's the brand name, and that is Trazodone as the generic medication. I see this used quite a bit in geriatrics, mostly I would say for insomnia as an off-label purpose. It is considered an antidepressant, maybe considered an atypical antidepressant. Trazodone increases serotonergic activity within the central nervous system by inhibiting the reuptake of serotonin and acting as an antagonist of the 5-HT2A, 2C receptors. Okay, so this combined action essentially increases the serotonin action in the brain, which has obviously been identified as an important neurotransmitter in depression. Some of the things to pay attention to, very sedative. It's very sedative in nature, so it can cause drowsiness. So we really got to be careful, about operating machinery, driving, that type of thing. Really, really important from an adverse effect standpoint. Also can cause some confusion and may increase fall risk in geriatric patients. Dry mouth is probably one of the more common nuisance adverse effects that patients have reported. And then kind of in addition to the sedative type properties, we can have some orthostatic hypotension as well. So again, that drop in blood pressure potentially causing some dizziness there. Rare adverse effects, we've got serotonin syndrome, any drug that increases the action of serotonin. Obviously, we can have that risk there. QT prolongation, not something I worry about too much with this medication, but if you've got, a patient on, numerous QTC prolonging medications, and or maybe they're at risk for that already, that's a potential issue to pay attention to. It does carry the boxed warning for suicidal ideation, suicidal thoughts, and then priapism is kind of a rare adverse effect reported with this medication. Drug interactions. So MAOIs, it is contraindicated to use an MAOI within 14 days of the use of Trazodone. It's an increased risk essentially for serotonin syndrome. And then we've got CNS depressant additive activity. So again, Trazodone, it's sedative by nature in itself. So when we add opioids, gabapentin, alcohol, barbiturates, these can all increase the risk for that CNS sedation, particularly maybe in the case of, like opioids and benzodiazepines, we can increase that risk for respiratory depression potentially as well. Serotonin syndrome risk I alluded to as well. Any drug, that increases the amount of serotonin, tramadol, SNRIs, SSRIs, this can potentially increase the risk of that serotonin syndrome. QTC prolongation, I alluded to that already. And then there is some action by CYP3A4. So CYP3A4 inhibitors, some of the azole antifungals, for example, these can raise concentrations of Trazodone, whereas inducers, carbamazepine being a good example there, St. John's wort, these can actually reduce the concentration of Trazodone. All right, last medication, number 180, is Pioglitazone. Brand name is Actos. This is considered a thiazolidinedinone. Again, very tough mouthful to say, so you'll hear it abbreviated as TZD. It's an anti-diabetic agent used to lower blood sugars. So the indication obviously is going to be type 2 diabetes. And in patients who have heart failure, we really got to be careful with this medication. Okay? So that's one of the biggest things, the most highly testable thing probably in patients with heart failure and diabetes. We're probably going to absolutely avoid this agent because it can worsen that heart failure type situation. Mechanistically, how does it work? How does it lower blood sugar? It's what's called a PPAR gamma agonist. So it basically decreases insulin resistance in the periphery. Okay, this leads to increase in insulin uptake in the periphery and obviously a reduction in hepatic glucose production and blood glucose in general. It is a very convenient medication, and it's at this point fairly inexpensive. So we've got a lot of newer diabetes medications, SGLT2 inhibitors, GLP-1s. And at this point, as I'm creating this podcast, they're all very expensive. Pioglitazone is relatively inexpensive, once daily dosing. And by itself, we typically have pretty low hypoglycemia risk because it doesn't stimulate the release of insulin, or it's not insulin itself. Adverse drug reactions, I alluded to the edema risk and worsening of CHF. So that's probably number one thing you're most likely to be tested on or asked, on clinical rounds or wherever you're at. Weight gain can be associated with that as well. So generally not a good thing in type 2 diabetes patients who are, oftentimes overweight to begin with. Other things to kind of think about with this medication, bone fracture risk, osteoporosis risk has been reported. That's something I do pay attention to periodically, particularly in patients on this medication for a longer period of time. Maybe they've got other risk factors, female, older age, that type of thing. So pay attention to that. In addition to the heart failure risk, there is potential for elevations in liver enzymes. Again, not very common. And then the other thing was bladder cancer as well. Again, very, very rare associations here. But just something I wanted to mention. All right, drug-drug interactions. So first thing I think about is kind of that additive effect on edema. NSAIDs, calcium channel blockers. These are all medications that can increase edema as well as pioglitazone, so kind of having that additive effect. Hypoglycemia risk, I think that kind of goes without saying. If we add a sulfonylurea, if we add insulin on top of pioglitazone, we may be a little bit more at risk there. And then CYP2C8 inhibitors. Gemfibrozole is a good example. I think I did that on a previous podcast, or maybe one or two before I did gemfibrozole. And it being a CYP2C8 inhibitor may lead to increased levels of pioglitazone, because pioglitazone is significantly broken down by CYP2C8. All right, well, that's going to wrap up the podcast for today. Thank you so much for listening. Do me a huge favor, share us with friends, colleagues, leave a rating, review on iTunes or wherever you're listening, and support the sponsor, meded101.com/store, with your purchases there. Always greatly appreciate that. If you have any questions, comments, feel free to reach out to me, mededucation101@gmail.com. Do my best to respond to everybody, usually within 2 or 3 days. So try again if you haven't heard back from me within a week. I do get quite a few emails, but I do my best to get through them all. So again, greatly appreciate all the kind words, the support on the podcast. It means a lot for sure. And I hope you're learning pharmacology and being able to use it in practice. So thanks so much for listening. Take care. Have a great rest of your day.